Good afternoon, everyone. Welcome to today's session of Crisis of Caring Conference that's being presented by the National Humanities Center. My name is Dr. Kari Nixon, and I teach medical humanities in the English department at Whitworth University in Spokane, Washington. My work focuses on collective public anxiety in response to public health communications during times of epidemic disease outbreak. I'm one of your panelists. I'm also the moderator, though. So just briefly, some of my publications have been in May 2020. My first academic book was published called Kept from All Contagion, Germ Theory, Disease, and the Dilemma of Human Contact in the Late 19th Century. And this past year in June 2021, my public-facing book through Simon & Schuster called Quarantine Life from Cholera to COVID, What Pandemics Teach Us About Parenting, Work, Life, and Community from the 1700s to Today. I'll be moderating this afternoon in the panel Caring and Understanding in a Global Health Context with my fellow presenters, Adria, Imada, John Mckiernan-Gonzalez, and Alexandre White. I'll briefly introduce each of them just before we begin, but you can find more extensive information about all of the conference presenters by visiting the National Humanities Center's website. Adria Imada is professor of history at the University of California, Irvine, where she also teaches in the medical humanities program. Her recent book, An Archive of Skin, An Archive of Kin, explores the prolific visual culture of kinship and disability produced to document the lives of those suspected of having leprosy in colonial Hawaii. And she's currently at work on another project examining survivors of epidemics in the US and its colonies in the 20th century. John Mckiernan-Gonzalez is the Jerome and Catherine Supple Professor of Southwestern Studies and an associate professor of history at Texas State University. He's also a director there of the Center for the Study of the Southwest. His first book, Fevered Measures, examined public health campaigns along the Texas and Mexico border in the latter half of the 19th and the first half of the 20th centuries. And his co-edited volume, Precarious Prescriptions, considered the contradictions and complexities tying medical history and communities of color together. And finally, joining us from Johns Hopkins is Alexandre White. Alexandre is jointly affiliated with the Department of History of Medicine and as an assistant professor in the School of Medicine, and is an associate director of the Hopkins Center for Medical Humanities and Social Medicine. His current book project, Epidemic Colonialism, A Social History of International Disease Response, will examine how certain epidemic outbreaks became global threats, that is, diseases that elicit international regulations and organized responses, while others do not. So welcome to everybody joining us and to all our presenters. We'll begin discussion among the panelists. I have some curated questions that I'll deliver and we'll all discuss together. And in the last 30 minutes or so, we will take audience questions. For those of you who are viewing on YouTube, please feel free to enter those questions or comments in the chat at any time, and they'll be funneled over to me as the moderator. So I thought we'd start with sort of a broad question, which is how can local knowledges, this is something that each of us has studied in different sort of locality-based contexts, how can local knowledges be brought to bear on global health equity? And whoever would like to begin can just hop in.
I can jump in first. Oh, John, go ahead.
Oh, Sasha, no, you go ahead.
All right. Yeah. Well, first off, thank you so much for having us here. This is terrific. I think one area. So it's really since the pandemic began, I've found myself working more and more on local U.S.-based public health initiatives, especially relating to vaccine access and vaccine equity. And what I think from a sociological perspective, what we far too often miss when we look at the sociology of epidemics is the role of community organizations and community actors in responses. And I wonder about, and I think this is also a question of kind of where we draw theory from and where we draw our ideas from, because I think about research that I've done on Ebola in West Africa and the ways in which community actors were much more in advance of some of the activities that the WHO, Doctors Without Borders, and others were engaging in terms of contact tracing, in terms of finding care for people with Ebola and their families. I wonder about how we could reinvestigate and reconsider public health responses, both comparatively and globally, by thinking about this very critical role of community actors and agents in this, especially when, as we saw in the United States, state, local, and national responses are weak or patchwork together. And what sort of space does, what sort of role do communities serve in really providing those necessary needs that are missing?
That actually makes me think of something that we've been talking about in my classroom lately, a very related point of one of my first books was an edited collection called Endemic that I co-edited with Lorenzo. And in it, there's an essay by Claire Hooker and a few other scholars that really advances this point that even the way we define epidemic versus endemic has so much more to do with what we already socially are biased towards or want to shove away and disregard or normalize. And so this is something I thought about during the 2014 Ebola quote unquote outbreak in America. I was actually living within walking distance of the hospital where all the patients were at that time. And I could walk down the street and see them emptying one of the nurses' apartments into this sort of biohazard containment U-Haul truck that had been decked out to look a little bit more official. And one thing I always have my students think through is how Ebola was rather not really taken quite seriously in the West, I think, until we had something like 5 cases here. And then it became an outbreak or an epidemic, which is something Ann Finger has mentioned as well about polio, for instance. And I think we can see it with so many diseases, that label is not so mathematically bounded as it is socially, right?
Absolutely. I mean, I think that in looking at the histories of international infectious disease control from a regulatory perspective, I think we see the ways in which the concept of an epidemic is so much scaffolded upon the threats from, really the world beyond Europe and North America, encroaching upon and potentially emerging in kind of this supposedly, unaffected Western space. And I think we saw this realization coming up so much in COVID. And I think it was, so much to our detriment. It's what I call in my book, Epidemic Orientalism. But even I think back to I think it must have been between March and May of 2020 when then President Trump, speaking in a moment of candor, he said essentially, I look at my local community in Queens and I see, I see refrigeration trucks filled with bodies outside of hospitals. This is in Queens. I've never seen anything like this before. And he said, I've seen this I've seen this on TV in faraway lands. And I think this idea of an epidemic is something that happens somewhere else has been a really dangerous framing that is obviously, I think no doubt led to significant loss of life.
Yeah, something that Hooker et al. Say to that point is that, and they say we're intending to be provocative here, that viruses don't kill people. People create the conditions in which viruses spread and proliferate to certain groups. And perhaps a bit reductively in my public-facing book, I've said that this fantasy that the disease, whatever it is at the moment, HIV or Ebola or COVID, is going to stay over there is the thing that in fact lets it spread the most widely, right? So it has this biological consequence as a result of our social imaginary. John or Adria, do you want to jump in on any of these points?
John, why don't you go ahead?
Nice. Way to do to me what I did to Dr. White. Thank you. What I I've actually sort of like got caught up in the word global, which is how, like, one of the ways in which people sort of like understand global is through these institutions that name themselves as international, and sort of like asking for a global response necessarily sort of like removes sort of like local actors from the particular conversation. I have to say that sort of like living in Texas, the boundary between Texas and Mexico sometimes is what Gloria Sandua calls la herida abierta, the open wound that bleeds on a regular basis. So, the separation between first and third world is reasserted over and over. It's medical, it's crime, it's drugs, it's avocados, what have you. It's trucks right now, and that kind of thing is sort of like done over and over and over again. So that's the thing that I get caught up in. I think it's really interesting to think about like what gets called global, what doesn't, and what sort of like calls for global responses versus sort of like very effective local responses. And that, of course, is always troubled in these ways.
Yeah, I was just a couple of weeks ago, I was on a panel with David Barnes from Penn. And somebody asked on the panel, does it matter whether we say epidemic or pandemic? And I'd like to hear, John, how you respond to that just initially.
Well, I mean, again, as a historian, people don't write about the pandemic of dysentery. People don't write about the pandemic of tuberculosis. People don't write about the pandemics of colds because it's taken for granted. It's sort of like part of what we live with, and it won't actually attract the kinds of book sales or attention that people want. Epidemic, I mean, all the way back to Charles Rosenberg, it strikes at sort of like certain ideas of what the ideal bodies are and how they're affected. That sort of like allows for particular kinds of action to come through. So as someone teaching a class, you ask students to pay attention to like when that rhetoric gets put into place. But as someone in the historian of medicine, someone who kind of uses history to think about these things, it's more like, well, let's take a long term. It doesn't quite capture the urgency of the moment and situations. Like taking a long view when people are dying in striking ways doesn't move things in the way that perhaps it should.
So I wanted to pick up on some of the threads so far, particularly around local community actors and the agentive kind of possibilities of paying attention to those knowledges. First, speaking of the local and kind of important embodied political structures and practices, I did want to begin by acknowledging with my own aloha for the Ahashmin and Tongva peoples on whose land I have been teaching and working for the last 15 or so years, as well as the Kanaka Iwi of the Hawaiian archipelago, where I was born and raised as well. And I am a settler descendant from Hawaii, but I also do research on indigeneity. So I think thinking through relationships between failed relationships between indigenous peoples and the settler state are, it's a really important sort of entry way into this discussion. But during the pandemic, I have become a little bit obsessed with thinking through the kind of visual maps, right, of the way that the pandemic has been traced through COVID dashboards, right, for instance, and the kind of ubiquity of this systemic kind of aerial data, kind of to use that analogy, and the way that the view from above gets interpreted by epidemiologists and disease hunters, right, germ hunters. But I'm really, perhaps because I am a cultural and social historian, I'm really much more interested and believe in the value of the view from below. So in other words, to kind of flip the James Scott, right, as much as I value his work and draw from it, like it's not really seen like a state, right? What is it like to see, to keep in mind like the perspective of the state, but what about the powerless people, right? And peoples past, present, right, and ongoing who get caught in the webs of the state, right? How is it valuable to kind of look at how people beyond the kind of COVID dashboard, like what are they doing to respond as you know, Alexandre, Sasha, you're saying, right? And so unapologetically, I think it's really important to keep in mind the kind of everyday lived experiences of ongoing epidemics, past epidemics. And I think we can learn from the way that people cared for each other, the kind of grief, right? Even of the materiality of bandages, of blood, right? Of tears that we can use to think through how do we survive.
Yeah, that's such an important point, and one that I was wondering how to segue to. So I may be asking you to speak more into this or anybody else, but I've been thinking a lot as I move my own work to more like sustainability practices and health in sort of the WHO One Health model of the integration of natural and human animal health. The ways in which indigenous knowledges could have been speaking into this role. I think if Western voices would quiet down. I'm thinking perhaps, for instance, in my work on typhoid, and we learn how little the West knew about proper sewage disposal, and there were these knowledges out there that would have prevented diseases. And so I'm thinking about what you said about local knowledges from the lived experience. And just to throw one more thought out there, I often ask, and I don't know the answer, but I often ask if a non-Western oriented praxis of epidemiology would even seek to pinpoint things like patient zero, or if that's coming from a very perhaps individualistic sort of American Western sensibility, and what might the science of epidemiology look like if it had a bottom up instead of a top down approach, as you say.
Like, I think a lot of that work, I'll just answer really quickly, and I love to hear what the rest of you have to say, but I think that a lot of that work is already being done in Indian country, right? And from indigenous communities and just self-supporting caregiving networks, thinking about Native historians, First Nations people who are actively recognizing the connection between ongoing effects of colonization, right, and ill health, right? Just to be able to put that out there, that Native peoples without sovereignty, right, leads to like sovereignty is a kind of key component of health, right, on an individual level as well as in a broader kind of collective systemic way of conceiving of health.
Such a great point. Thank you. John or Alexandre, do you, either of you want to weigh in on that?
I'll go ahead and actually kind of do a prop to myself, but also to sort of like rethinking sort of like what the relationship is between the university and local communities. I put a small little op-ed for the NYU Latinx project that kind of pulled up some things from my book, Fevered Measures, which looked at quarantines along the US-Mexico border. And I highlighted this quote, "We, the undersigned, being mostly widows with families to support with our own hands, would represent that on account of the pest which has most unfortunately attacked our city, most of the well-to-do families that have given us employment in doing the washing, ironing, sewing, and et cetera have left the city. And since then, we have been unable to find any work, and we've been thrown suddenly, wholly on our feeble resources, with large families to support and no means of doing so. Hence, we humbly petition the Honorable Mayor and the Board of Aldermen, either aid us in obtaining work or to furnish us with means with which to support ourselves and our families while this epidemic lasts." Well, 2 weeks later, the head of Domésticas Unidas in San Antonio, Mariceli Herrera, read this petition, which was written in 1903 to the San Antonio City Council, asking them to provide direct aid to the domestics and home care attendants in San Antonio because they'd been locked out of the federal emergency response since they were undocumented and not able to access the process. But she sort of like called on this broader history of kind of like, what do you do in the middle of quarantine, and was able to sort of like put it into practice. When I went back to speak to Araceli to see if I could, because I'd heard about this and I was just really thrilled, she said, well, please remind people of our ongoing work, organizing with domestics, challenging sort of like the human trafficking, labor exploitation practices that keep us by there. And for Araceli, like healthy work conditions for her meant sort of like legalization, recognition kind of work, providing a level of respectability, but also when you tie this into sort of like the broader history of pandemics and epidemics and the relationship between US, Mexico, and indigenous communities, who was actually providing the care in the middle of these pandemics, who was being called on to do this when there were direct military attacks on sort of like Native communities. It was Native women who were providing the care on both sides of this border that was being created by the Spanish Empire, by Mexico, and then by the United States.
Related to this point, we have a question coming in from the audience on YouTube, which is just a slightly different way of talking about some of these ideas. Miriam says, could you talk about how any of this might relate to situated knowledges, which connects really well with local and indigenous knowledges? I was just reading Haraway yesterday out of the blue, but I'm gonna let somebody else have some airtime if they would like. I think Miriam, and you guys can jump in if you would like. I think situated knowledges would be kind of a synonym for a lot of what we're talking about. However, when Haraway developed that term, it was before a lot of the more recent work on indigeneity and local knowledges. Adria, I don't know if you want to speak into that more and contextualize it all, or.
I mean, definitely think of them as related, like feminist science studies practices, also decolonizing methods, right, and practices are also, these are not distinct kind of frameworks. And I think a lot of this knowledge is I mean, part of what John was signaling, right, is the kind of porous nature of what we do in the so-called university and relations, continued kind of relationships across to community, how, you know, broadly conceived. But so much of my own work is informed by organic intellectuals, right? People like who are writing those kinds of letters that John, you know, read from, the kind in my own work, the, you know, so-called situated knowledge of people who are petitioning to remain connected to people, to their loved ones who are medically incarcerated and subjected to colonial systems of carcerality and medical quarantine, right? These are parts of the kind of survival practices that are really important to keep in mind, right? That sustained people, not just in the moment, but over the long durée.
Yeah, connecting to some of your work on leprosy, I was just thinking of a talk I gave this summer on like a small micro history of leprosy measures in Southwestern Norway, and comparing them against a set of archival texts, which most people think is about cholera, actually. There's a play that everybody thinks is about cholera. But if you look at what was going on in that part of Norway at that time, you see that their biggest concern in that moment was leprosy and how it affected the community. And so I think even in that Western example, we see the need for people doing this really tough work in these small localized histories in the areas that you guys are all working in, because I think sometimes only getting down to that more microscopic level can we see some of the individual concerns that were affecting the community and avoid perhaps presentist or anachronistic assumptions about those localities. I'm going to pivot a minute because I think we've kind of been on this topic a bit, and I'm noticing doesn't seem like anybody's wanting to jump in as much. The next question that we've sort of crowdsourced here is, since the establishment of Medicare and Medicaid, in what ways do hospitals build on the work and resources of their local communities? And in what ways do hospitals displace and challenge the work and resources of local communities?
Well, that's a terrific question. You know, I mean, I'm not sure that I'm going to answer this with respect to Medicare and Medicaid, but I think that, you know, speaking from Johns Hopkins, you know, I'd be remiss if I didn't mention the fact that I think, you know, both the role of university and private hospitals, which are overwhelmingly often situated in more financially or materially deprived areas, rarely end up, you know, by virtue of both internal policy, but also the nature of the US healthcare system, rarely end up serving effectively or at a low cost level the communities that are directly around them. And oftentimes, you know, speaking also in the case of Hopkins, actively dispel and remove people from the areas around through gentrification practices and a host of other mechanisms. So I think, you know, the question is a really important one in terms of thinking about actually what sort of interactions are foreclosed, and also what sort of interactions could even be possible should community actors wish to engage with, or communities wish to engage with those healthcare systems. I think it's a really complicated and incredibly fraught question from the perspective of the community, because the histories of especially university hospitals and research hospitals has not always been one certainly purely of care, but also experimentation, observation, and you know, I think the very sorts of medical colonialism that Adria's written about, that John's also written about, and I think that's very important to recognize, especially when we think about how we frame healthcare support and public health interventions when it comes to an epidemic or a pandemic, because those legacies are, you know, not in the far past, but are very recent and ongoing, and that's a very critical element of, I think, so many of the failures of our national COVID response in the United States.
Thank you. John, Adria, Alexandre called you out and said you've written on this. So what would you guys like to add to that, these contemplations?
I can step in a little bit with a slightly different take, because I, from the context of Hawaii, I've written and thought through the long history of carceral medicine, carceral medical practices, and in the Hawaiian Kingdom, the subsequent territory Hawaii, and then the settler state, right? Hawaii is a 50th state since 1959, and it's a really complicated sort of matrix where the healthcare system that we have today, you know, some of those original, the original hospital, Queen's Hospital, was the legacy of an elite of the chief Emma, and so it's the Queen's Hospital. It's serving. It was meant to serve the public. At the same time, so many white settler physicians were able to become part of that larger board of health structure that then incarcerated people who were deemed insane, right, disorganized, immoral, illicit, helps you create a larger carceral network of juvenile delinquents, right, who are being placed in industrial schools, consigning people who were suspected of having leprosy to lifelong exile, which is what I read about, as well as the establishment of so-called insane asylums, according to a kind of colonial model of able, one might say today, able sanism, right? At the same time, there are really complicated matrices of beneficiaries who are both who are dependents on this system that was meant to serve Native people, not necessarily, and settlers to a certain degree. So even though I think it's useful to think about the way that settler descendants like my own family, right, are so dependent on this medical system, which is not necessarily set up to think about them, right? But we have become very dependent. My father just had surgery at Queen's Hospital. He had a bad accident during the pandemic, got taken to the nearest trauma center, which is the Queen's Hospital. Then when he needed a pretty significant operation in the end of 2021, also the only place that's available, right, for people to receive this kind of critical care and even trauma treatment is Queen's Hospital. And that's where most of the COVID cases were, that's where they saw they were the frontline workers for the state. And so I think it's really interesting to try to untangle, right, the way that both settlers and natives have contributed to this carceral medical network, but also have been beneficiaries. Right? As Queen's Hospital is trying to figure out now, proposing a kind of expansion, there are also larger structures in place that need to be taken into consideration, including whether or not there's going to be enough water to sustain this. And that's another conversation about a militaristic a system which has possibly permanently damaged the main aquifer on the island of Oahu.
You've given us a lot to think about. I was furiously jotting down notes for further strands of conversation. But I don't want to move on, John, without giving you a chance to weigh in if you'd like to.
Well, that question sounds suspiciously like a question I posed, because I was really interested in hearing what people would have to say, because thinking about hospitals in terms of studies, one of sort of like the key hospital that comes up is Lincoln Hospital in New York, which was of course put up to help treat people who had been formerly enslaved in the area, treated as a place where formerly enslaved people and their descendants were treated. And then a group of young Puerto Ricans and other Latinos decided to take it over and turn the hospital for the people. It's a really sort of like tangled place in Latino histories, as well as sort of like the radical history of medicine, because Fitzhugh Mullen served there, was part of the doctors that helped the takeover as well. A lot of Puerto Rican physicians worked there, and they already had a fairly social and community-oriented outlook to there. Local 1199, a lot of activists came out of there to become part of Local 1199, which is service workers unions and hospitals in the New York area. So it's as it stands, it looks like an either or question, but I think, and I'm going to say this again, being in Texas, just because you have a building there, it isn't the building doesn't establish the relationships. It's the sort of like systems that put people into place in that particular area. In that case, let's see, people had tuberculosis or needed abortions in Lincoln Hospital, people in car accidents like Adria's dad, who I hope is recovering from his time in the hospital, is really important. And I think it's just try to unsettle the relationships and try to create more sustainable relationships with the healthcare units and healthcare systems in which we live, and realizing that they're both a growth industry and an effect of the larger sicknesses and illnesses created by living in a settler state, in an industrial economy, and a deindustrializing economy. But yeah, I think, what is it, Clifford Geertz? I think hospitals are a very good place to think in terms of how they work.
I can't even decide which strand to build off here. You mentioned that hospitals reveal the sort of inherent illnesses in living in the way we've structured the world at present. And this is something in the 1880s where I work on that I see as the primary urgent warning of most doctors and thinkers, is that physical disease reveals what was already diseased systemically in our society. So this leads to another question that you may have posed, John. Who knows? We'll see if you recognize it. Given the ways that COVID-19 has shaped all of our lives, from employment and food access to mental health, how can we understand the concept of care for infectious disease beyond solely the treatment of its pathogenic effects? To some extent, this is stuff we've already been mulling over, because I think as like social historians of disease, like this is what we're thinking about beyond the pathogen. But this is sort of gives you more free rein to talk about any aspect of that you would like to. That's for any of you that want to jump in.
Sure, I can jump in on that. I think this ties back. I think both to earlier question on situated knowledges, and also actually, ultimately to this kind of the way in which the word global, and when we invoke the global, it covers all manner of sins. I think that the ways in which we've framed epidemics as emerging from certain places, traveling to others, the concept of an origin point allows us, has been very, or I shouldn't say allows us, but has been very effective in providing the basis for envisioning and mobilizing, be it in the 19th century or early 20th century, particular forms of colonial violence, quarantine structures, a host of things. In the present, isolating certain communities, neighborhoods, individuals, and I think that these forms of pathogenic control that have historically been rooted explicitly in thinking about how to maintain the mobility of some while allowing for the maintenance of global economic flows, but restricting the abilities of others to live and exist in a variety of ways. I think it's really important that we reconsider notions of care and reconsider notions of health beyond, and I think also, and particularly challenge and confront the underlying discursive frameworks that produce our understandings of what health is, what our understandings of disease as a biological, social, economic, political phenomena are, fundamentally to think about different ways of caring and different ways of thinking about health, not just as being freedom from disease, but actually a more holistic understanding. And I think that this would allow us to think about practices of care that attend to the structural conditions that produce illness and produce differential systems or differential effects of epidemics, for instance, on different communities in a way that doesn't pathologize them for being sick, but rather recognizes how segregation, access to public transport, access to working from home structures very different epidemics for very different people, and how we need to address that.
Absolutely. I couldn't be more in agreement. That's back to that local knowledges, right? The localized experience of pandemics is going to be different. And we saw that the experience of COVID could be striated across class boundaries, right? The people that couldn't not go to work, the people that were able to quarantine at home, for instance. And again, yeah, I'm kind of obsessed with the question of why do we even have an epidemiological methodology that's so fixated on finding an origin point? And I think one thing I try to work hard to promote, and I'm sure you guys are probably have had to do this too, is to work against the notion that the medical humanities is any sort of has a goal of debunking sciences, but that in fact we're trying to help science avoid the problematic biases that it has made missteps into in the past so that we can develop better science. And as far as like origin points go, I'm always asking students. I wrote a little op-ed for CNN, but they wouldn't let me go this far because they were like, you can't say epidemiology is wrong. And I was like, well, I'm not saying it's wrong. I'm saying that if we're always finding the origin points in suspiciously and conveniently the same areas and not other areas, I mean, data is messy. Data is not normally that clear cut. So we should be asking what systemic biases have been packaged in to those quantitative research methodologies. I was originally a statistician, and so I'm always like, there is bias. There is bias in how we structure these questions. Or per Priscilla Wald, of course, the question we're even thinking to ask, like you say, the focus on this origin point. Another thing that I've been thinking about as I listen to you guys is how often, and you've kind of just said this, Alexandre, but I thought I would see if John or Adria wants to weigh in as well, is that this same sort of set of values seems to create an assumption that health is one thing, which is not disease, rather than access to secure housing, which hospitals can displace people from, access to food, access to work, which John brought up, sovereignty, which is, I think, Adria, you mentioned, it could encapsulate so much of this, but we really, in the traditional academic disciplines, there's not a deep enough recognition that that should be considered a determinant of health. Do you guys want to add just anything else to this? It's such a rich question.
I guess I would say that, the pandemic is just one crisis, right? And I think crisis can be useful, right? Insofar, not so much in terms of like, mortality, but crisis in terms of creating possibilities for, I'll say, fragile solidarities, right? They're revealing, crises are breaking points. They expose, and they also can create different kinds of inventive or imaginative solutions. So I'm just interested beyond, and these are the kinds of questions that I've been thinking through, and I want to make a plug for two kinds of projects that I think have been really useful to think about the work of imagination, right? And history, memory, dreaming, right? And shaping sovereign and healthy communities. And the first would be Brenda Child, who is a professor at University of Minnesota, American Indian Studies, and just a Guggenheim awardee, I think, in the last week. And she's been doing this amazing public history and visual work of documenting the jingle dress dance in Ojibwe communities. And you can look this up on YouTube and see the way that this, which the jingle dress, she explains it much more eloquently, but a dress that Ojibwe women and also other Native American women picked up on that in the aftermath of the 1918-1919 influenza pandemic. And they've taken this healing dance, the sound of the bells on the dress, right, that they created was thought to be sonically and emotionally healing. And this is picked up during the pandemic. They've taken this to powwows and other kind of community sites, even George Floyd's, the site of his protest, right? And so I think it's a really wonderful way to think about embodiment, right? And the work of solidarity that is created at a moment of crisis. The second plug I'd make is something I just learned recently from a really wonderful junior scholar, pre-tenure scholar at Wesleyan University, who's Filipina from Guahan or Guam, named, you can look up her work at Kristen Oberiano, Oberiano, who has co-founded an organization in Guam that, so another crisis point during the pandemic is food insecurity, particularly in small, so-called small places, locales in the Pacific Islands, Guam being one of them. So she is working in a smaller group with other Filipina settlers in Guam to work on food security. So beyond corned beef, spam, et cetera, right? Teaching people how to grow their own gardens and create local food sources rather than being dependent upon a really expensive imported canned foods. So those are just some ways that I kind of point to wider kind of imaginative responses to crises.
I have a student actually working on a project to that regard. My students have to do a digital advocacy project at the end of the semester, and she's from Tonga, and she's doing a project to actually per Hooker's work, where she talks about the way that TB is endemic to certain Pacific Islands, but largely because of dependence on Western food sources after colonialism. And she's doing a project to go talk to different elders and find pre-settler recipes and to develop them into a cookbook to give to her community. So like these, I love that, as you say, that when there are these rents in the social fabric, which is essentially what disease is, there are these opportunities to rethink what we've been doing. And for me, I hope that enough people take advantage of that instead of just going back to the status quo. John, do you want to add anything to this discussion at this part of the discussion? Obviously, you've added to some of the discussion already.
I feel I just want to blurt disability studies right here and then go, there's so much there. But I think part of it is thinking about what is the antonym to illness. Is it health? Is it sovereignty, as Dr. Imada pointed out? Is it democracy, as I pointed out in another essay? And to sort of like think that through. And the other thing with sort of like disability studies is, of course, no one has like peak ability. No one sort of like meets those normative ideals, but people live with these various kinds of disabilities or challenges in particular ways. And thinking that as the actual normal that people kind of run through is really important. And there's so much more that can be said around that, but I'm just going to leave it right there. I think Stephen Thrasher in the Viral Underclass discusses this. And then if you go, Disability Twitter is a really good place to sort of like have your assumptions challenged on a regular basis.
Yeah, that's so important for us to make sure that's part of this. I've long thought, and I don't know how you guys sit with this, but I've long hoped that disease studies in medical humanities could be sort of a further development and a further provocation of the questions of normativity that disability studies raised.
And I mean, and I actually do want to go back to sort of like the crisis question, and I think organizing. One of the things that happened in Austin, and this is, I guess, a local knowledge is like locally where I am right now, is that schools became places where free lunches and free meals were distributed. Schools had the ability to scale up and start providing food, not just for the parents of the families, but for people in the particular neighborhood who could get there. Folks, this is pre-vaccine, you wear two masks, pass things out, and they became key places to sort of like organize around different issues that were happening, to tell people about mortgage evictions. And I think the crisis had showed a lot more people the kinds of work that parent support specialists were actually doing in these public schools. So in a sense, is like when you asked us, like, what's the difference between endemic and pandemic? What's the difference between crisis and normal? Or what are the crises that we're all bound to attend to? And what are the crises that we're bound to ignore?
Such a good point. Yeah, at our my university is rather small, and so when we were shutting down dorms, my big concern was housing insecure students. I think there's this assumption that at small liberal arts schools that are perhaps expensive, there's not home insecure students. But when I was an undergrad, I was a homeless undergraduate student at an expensive liberal arts university. And definitely nobody knew that I didn't have a place to go when the dorms closed, right? And so, as you say, this reveals these moments where people can speak into those locally lived experiences and say, this is the crisis of the norm, right? I'm thinking of Bruno Latour, like, we've never been normal, like we've never been healthy. Really, really great point that complicates a lot of, I think, the assumptions in these conversations. I'm trying to, I think we have a few more minutes. Okay, I have a question that I came up with while I was thinking, listening to you guys. We hear a lot about the discussion of frontline workers during the pandemic. And I'm thinking now of my sometimes co-editor, Lorenzo Cerviche, and his monograph that's just come out on the use of martial language when we discuss disease, which of course he notes to be, he thinks, quite problematic. And I'm wondering, given all we've talked about with indigeneity and disability studies and colonial violence, if you guys think that there is a fundamental way in which those metaphors might perhaps be dangerous in their own right. Or perhaps maybe not dangerous, but maybe another way to frame it is, how do you see those ways of phrasing things informed by or informing some of these problematics of care that we're discussing?
I think in so many ways that's a fundamental question of history as well. I think that the something that I teach to my students in the School of Public Health is that when we think about some of the most significant public health operations, especially American and British colonial and French colonial public health actions or colonial medical actions in West Africa, in Latin America, in the Pacific, and really everywhere, Africa, Asia, the Pacific, and in the Americas. These were military exercises. William Gorgas working in Latin America and Panama in particular, this was doing military exercises to eradicate mosquitoes, to prevent the spread of particular vector-borne diseases. And I think that the martial language that we have is not just, it's not just metaphor. It's not like just that we're fighting disease. It's like, no. Soldiers historically have been used for this work, and military agents and actors have been used for this. And I think that this all brings to mind something that we've been, talking about significantly, which is that the colonial legacies of public health and the colonial legacies of disease control and the colonial perspectives that have become so much more visible during COVID, are not the distant ancestors, but kind of the still living grandparents that we're navigating and negotiating in the present. So I would say, it's a luxury of privilege to think that we've removed ourselves from 19th century logics about infectious disease control, fundamentally. And I think that the martial language, as I said, is not just a metaphor, but it's doing work, and it's doing and reproducing violent work historically that's been in action. I think we need to figure out ways of thinking away from that. I think, and I just want to add that, something that Dr. Mckiernan-Gonzalez mentioned just before, the ways in which schools have become sites of healthcare provision, as they actually always have been. right? But the way they're being recognized as this now, the ways in which barbershops, community centers, other spaces have been mobilized by public health workers, community members, the broader general public, as sites for care, for vaccine delivery, for information dissemination. These are not necessarily the sort of top-down spaces and enterprises that I think much of infectious disease public health support envisions traditionally when thinking about these forms of response. So, and I think that elevating those, making those more visible in the sphere of public health, in the public, I think this is already recognized, but I think in the sphere of public health is deeply, deeply important, especially, as we think about future, any future health crisis, be it an epidemic or otherwise.
I guess I'd just add really quickly that what Alexandre's saying about the who or what is, what gets taken as aid, right? As medical, like the Marshall metaphors, right? And aid itself is not a neutral kind of delivery system, right? Of so-called care. And just thinking through, NGOs, and its relationship or global networks of kind of so-called humanitarian delivery of vaccines or aid, right? Most recently, or, in a recent example of the Tonga earthquake and sort of relief provisions that were supposed to be provided, Tonga did not want to have so-called care workers from New Zealand, et cetera, arrive because of COVID concerns. And they arrived, and then there was a COVID outbreak in a country which had been very successful at preventing COVID. It had its own kind of COVID protocols. So aid itself, right, is an extension of that kind of that Marshall and colonial network too.
Yeah, that's so important. I think particularly, at least in my teaching, I see a lot of college age people thinking, that a generic form of sort of help and aid is all that's required, and helping culturally to think through that is really, really critical so that we don't recapitulate the same systems that they are a part of. John, you're unmuted. Did you want to add something? Oh, okay. I'll take that for a no. Okay. They asked us to move to audience questions about now, so I'll do a couple of them, and then if we get some more, we'll go that way. If we don't get more, we'll pivot back to the questions. One question that got sent in is, what does the panel think about private healthcare agencies whose administrators haven't made any home visits for 2 years during the pandemic, leaving the burden to fall on low-paid workers?
I'm just going to be, go ahead, Dr. White.
No, please go for it.
I guess the first answer is not much. Like, who are these people? But the other thing is thinking, again, going back to what Adria and Imada discussed, sort of like the rise of NGOs or privatized agencies that provide a buffer between the state, allow it to become more of a market relationship. But the third thing is that these private healthcare agencies are actually regulated by the state. And if the state has a measure of democracy, people can sort of like put into things to have like home healthcare attendants be paid in particular ways. And this has been a petition in New York. Because Medicaid payments, because disability payments are regulated by the federal government, it can be regulated in particular ways. And I think it it behooves all of us to pay attention to the ways that this basket of benefits we call citizenship or residency come with certain work conditions. I think it's an organizing opportunity, and it's a daily crisis. And I'm muting myself so I can indicate.
I might add too that I'm thinking of Leavitt's work on Mary Mallon in 1906, that she notes that care work has often been something that, historically, since the rise of consumer capitalism, has been devalued and placed expectations onto certain groups. I think Leavitt mentions women in that context, but so this again is not something, as Alexandre pointed out, that is something that has stayed neatly packed away in a backwards Victorian past, but in fact is the legacy of the present that we've sort of inherited.
Yeah, and I think, just to add to that, I mean, I think that we've so quickly, I think this is where partly a challenge comes up in our language and health disparities, right? We often employ rather inagentic language when we think about health disparities, where in relation to COVID, it was certainly the case, where it's like, well, there are significant disparities in case rates and prevalence of COVID-19 amongst Black and Hispanic communities, especially, and like that makes it sound almost like there's some sort of natural association between these things. But the fact of the matter is that, in getting back to this really interesting question, is that we know that Black and Hispanic folk are disproportionately work in care sectors, disproportionately work in the healthcare sector, and we have to recognize the ways in which structural disadvantages are built in to the systems of care that we operate. They're not kind of it's not a negative externality, but rather it's kind of a feature of the structures that we operate with. And I think it speaks very much to the immense burden to maintain individual health that is placed on people against overwhelming epidemiological odds to stay safe and to stay healthy during a pandemic without very much support. And when we start denaturing the language around health disparities to think about that in this way, and I don't want to throw all health disparities research under the bus, but I think that there's a tendency to kind of depoliticize health disparities in a particular way. And I think we really need to have these serious conversations about how these structures, especially, and I think how the ways in which the commoditization of health in the United States produces these sorts of vulnerabilities in particular that are deeply inequitable is really important, and a conversation that I think has gotten more, has generated more energy since COVID, and as we've seen it kind of raising awareness about these critical issues.
And it extends beyond COVID itself, right? I was just teaching Samantha King's Pink Ribbons Incorporated, and we were going over with my students the ways in which the Susan G. Komen, like the sort of preeminence of the walkathon, there's something, John, there to be said for disability theory and the sort of race for the cure mentality outside of cancers. But King really notes in this really great way the way that these sort of positivity of these ballooned and festive events, which are overwhelmingly middle-class white populations attending them, make breast cancer seem like something that just happens to a body, rather than things, as Audre Lorde has asked us to do, that are done to certain bodies in certain places who have certain risk factors. And so I think, as you and Adria and John have mentioned, that COVID is opening ways for us to look at all health and health interventions. And similarly, the Komen model will be a good neoliberal citizen, get your mammograms early, work that Rob Aronowitz, the historian at Penn, has like debunked and said, there isn't actually great data to show that mammograms are adjusting mortality. But so there's this sort of flattening and normalizing of the occurrences of these, as if broad stroke top-down interventions could help the local systemic risks that people are exposed to. Somebody else asks, is there an epidemiologist on this panel? I'm telling you right now, I'm not touching this question with a 10-foot pole, so it's going to get kicked to y'all. Perhaps you could talk about the ways your work relates to or departs from epidemiology. John raised his hand, so not it.
Well, before going to grad school, I was an epidemiologist and I was a phlebotomist. So my work directly departs from my time as an epidemiologist for Cook County Department of Public Health. So that directly answers the question posed by Marina. But the other thing is just considering, I think Beth Eddy, who's also on the chat here, discusses sort of the way illness provides metaphor. But I will say that epidemics, or even sort of like the study of epidemics, which epidemiology allegedly is, as well as sort of like the other things also are studies of epidemics, provide kind of a shared conversation, a shared ground where I can discuss disability and illness in hospitals and settler colonialism with Dr. Imada, and we can think about epidemic Orientalism, because we think we might know what epidemics are, we think we might know what Orientalism is, but putting them together, I think, opens up nicely. And I just have to say, like, just because we name settler colonialism and we name epidemic Orientalism, it doesn't go away. So, and borders don't go away either. So I just think that when we think about humanities and the relation of medical humanities to other things, we are part of these larger conversations about Orientalism, about a relationship to the rest of the world, or we are part of the world that has a relationship to the United States as well. So I'm just putting that there as responding to the epidemiology question.
I guess I could jump in to also say that I work with a lot of epidemiologists on a regular basis. I'm not an epidemiologist, but I think that some of the work that, this is really just to tack on to what was just said, but I think so much of the work that we do and the role that the humanities and to some extent the social sciences play in thinking about the world of medicine broadly is that we're able to and have time to kind of think about where the underlying discourses and assumptions get baked into how how the practice of epidemiology operates. And I think that for so many epidemiologists, there's no time to do that when you're confronting fundamentally an epidemic. And I think that this is if we're doing, if and I don't want to make it sound like our work is exclusively normative or invested in the practical elements, but I think that the our investigations are so much about the underlying assumptions, perspectives, approaches that lead us to so many, I think, of the pitfalls that we see today with public health responses that I think intertwine with epidemiology in a variety of ways.
I guess I would say that here's where I think the political and social work of disability studies and disability thinking can really disrupt, right, so many of those questions that Dr. White just mentioned, that get baked into certain kinds of assumptions and organizational frameworks, right, or epistemological frameworks within epidemiology and medicine at large. So just really broadly, the binarism, or the assumption that the opposite, like we talked about antonyms before, that the opposite of illness is a cure. And actually a cure doesn't, a cure, or perhaps even in the case of COVID, a vaccine, right? The vaccine is not going to cure ill health collectively, or perhaps, perhaps on the individual kind of somatic level, but is not going to fundamentally unmake larger systemic problems, right? Of settler colonialism, of the Orientalism and colonialism, carceral medicine that we've already talked about. But one kind of essential set of kind of mediated thinkers that has been really helpful for me during the pandemic has been produced by Alice Wong. And if you don't know her work, it's really, really great in terms of elevating and amplifying the kind of diverse voices of people who with disabilities and disability activists, about feeling left behind, of making their own interventions in the COVID conversation, right? And really disrupting the idea that a cure or vaccine, in this case, would solve the problems of ill health and the pandemic.
Yeah, I'll just add a plug for Travis Lau's work as well to that end. Really good friend of mine and a great scholar. And there's some interesting ways in which I think, in addition to his work on disability studies, his work on vaccination was sort of appropriated by people who weren't acting in good faith and engaging with his work as he intended it. And so there's this really interesting colonization of scholarship that you can kind of see happening at times. As just a final little note to Marina's question about epidemiology, I'll add kind of to the way John responded that I think I was drawn to this work in medical humanities because of my first career as a psychometrician in a data science lab. And so I was sort of on the ground floor of seeing how I was supposed to be working on a PhD codifying the human personality, quantifying, I suppose I should say. And I think there were enough logical disconnects with quantifying something that seems so impossible to quantify that I was led to think through these assumptions that were baked into that. And I've seen this with a lot of scholars in the medical humanities. Many of them started as bioengineers or neurophysicists or kinesiologists. And so I think there is often this marrying of concerns for people who have sort of sidled over to different fields to keep asking those questions, but who are quite well apprised of the way the disciplinary standards go in STEM fields. John, you already alluded to this, but a comment on types of metaphors to consider. Healthcare as a commodity to be dispensed to others, and healthcare as a major form of relationship between greater than individual gatherings of humans. It's kind of a comment, but if anybody wants to unpack that a bit.
Well, I'm going to follow up by quoting Alice Wong, as Dr. Imada mentioned. The world is a petri dish, and I guess health is a relationship among those of us in this petri dish we call home, in a way. So I think when we think about care, as Beth Eddy pointed out, there is a sense that there's that fee-for-service model, like you get care in particular places and there's a receipt that you can get for it. And then there's that bigger, broader, unpaid labor, which is families, which is the roads that get you from one place to another, that is also very much part of the system that cares for us. In a sense, like you do need these different scales to make these things possible. You do need to find ways to address pollution, to address difficult work conditions, and thinking about maybe thinking about infrastructure as care could be a useful project.
I guess one thing I've been thinking about is one realization during the pandemic is that it's essential that caregiving is supported by the state, but it is not exclusively the realm of the state, right? So you need to have both, right? It's not like you can opt out of state infrastructure, right? And that scale that John just mentioned, you need those different kinds of scales. And I think that I really liked seeing the kind of COVID public health public art that was coming out of Indian country, in particularly like just to cite one. I mean, there's so much interesting work that my students really loved in medical humanities, but produced by artists in the Cherokee Nation. And I'm sure you could find it. It's a sketch, a painting of Sequoia, 19th century leader who is saying, learn your language and wash your hands, right? So it's the relationship, making explicit that language, right? And language reclamation, being able to, is as a sovereign practice, is also part of this larger reclamation of health or practice of public health. Right. And it's an act of public caregiving, as is washing one's hands and staying, distancing and feeding one's elders.
I'm gonna shift for our last question, unless we get more audience questions, to a different concept, that of how to employ the knowledge that we collectively spend our lives trying to excavate and archive towards current communication lapses. So this question says, public health debates during COVID have gotten very emotionally charged. What strategies can both quantitative and qualitative studies in health communication provide us for communicating with people who have vastly different beliefs about public health than us? That is, how can we bridge the communication gap between two people who potentially hold mutually exclusive private opinions which they both believe affect the public health at large?
I mean, I think that's a really interesting question, and I paused for that long because I was thinking. I think it's something that deserves a lot of contemplation. But I mean, I think that part of something we really need to engage in thinking about are the ways in which the language of public health response constructs dichotomies of very I guess construct dichotomies of us versus them. The whether or not you're the adherent, docile vaccine recipient or recipient of public health responses, or you're the kind of I don't know, the resistant, hesitant anti-vaxxer. Like these are not, there's one is the noble subject, one is the errant one in need of control. While vaccine, the COVID vaccines have been incredibly effective at preventing significant illness, we needn't create animosities between people based on adherence to public health logics. And I think that betrays all sorts of issues related to histories of harm from the medical community. It betrays issues associated with access, issues associated with access to knowledge that far greater complicate these elements. So I think challenging the ways in which we construct notions of adherence to mask wearing, to other public health mandates versus versus delinquency, it sets up a particular, it sets up a certain carceral logic or criminal legal system logic that I think backfires very significantly. And if we can actually deconstruct the ways in which we linguistically produce these narratives of public health care and delivery, that would go a significant way, hopefully, to enabling mutual care for one another rather than kind of animosity and suspicion.
I write about the detrimental effects of criminalization, right? In this 100-year period of medical incarceration, and how Native Hawaiians in particular were seen as them, right? As the kind of culpable, illicit, morally contaminated communities that were, the spreaders of this bacteria, and therefore they were subjected to this very, very harsh processing, archiving, a visual archiving, and then a banishment, essentially. And that just led to people hiding out from medical carceral authorities. And we've seen this happen in many other communities, right, that are similarly viewed or treated as delinquent and criminal. And so I'm not the one that came up with this, but thinking about harm reduction practices in earlier with other kinds of public health and community-based practices with HIV/AIDS activism, it can be a useful way of reframing strategies, communications, and practices beyond the binary. So how can we reduce harm and in inclusive ways that do not vilify and criminalize?
I'm just going to sort of point out that this sort of anxiety over someone wearing a mask in a public place that they want to attend to, or not wearing a mask in a public place that they want to attend to, really sort of frames away the larger structures that both people want to be able to go to school. People want to send their kids to school safely. And I think if you sort of put it in the longer frame of these things, it's an actual conversation about public health and care and safety, which is, I think, rare or relatively rare in our current conversation. I guess not that rare, but it would be nice if we'd see more of that sense of public benefit, collective good in terms of those conversations. And I will also sort of speaking more broadly or more longue durée, I mean, over time, these are some blips, but sort of the general crisis of the ways that we have decided to distribute particular illness outcomes continues and still frames these experiences. So I don't know if there is a way to have public health language resolve that particular difficulty between someone who comes into what you consider being your space and breathes particularly disease-inducing COVID viruses in your air. But I think broadly, we can think about infrastructural interventions that can make it easier for people to deal with political differences without putting their lives on the line.
Such amazing answers, really helpful. Wow, we're getting through all these questions. How about in closing, what are the salient lessons and issues that we collectively are forgetting that we learned about care the hard way during the first 3 waves of our COVID pandemic?
I mean, I don't know. I don't think we have enough time to answer that question fully or comprehensively. I mean, I think there are several elements we touched on in very real ways, which is, I think one thing I think back on, and I think is very important in the both U.S. and global context, but I think in the I think something that is important for us not to forget are the ways in which and I should also say the global context, meaning just, I did use it as shorthand of outside of the United States, which is a problem. But I think, in broadly, I think we need to recognize the ways that the absences that were there at the beginning of the pandemic, both in terms of knowledge and in terms of material objects that were necessary to keep us safe. So the ways in which restaurants and stores, transferred over to provide home goods. People started, sewing masks for one another in particular ways, and then selling those masks when there was an absence or shortage of masks for the general public. All of these forms of engagement and public-led work that filled in the gaps that I think at the time public health didn't even realize it had. And while other countries perhaps were providing personal protective equipment to people, the U.S. especially struggled in this regard. And I think that we'll never know how many lives that wider communal action saved. But certainly it was a great many. And I think that we need to remember that and archive those histories and those actions in particular.
This is another question that we might not really have time to answer. Yesterday, a panelist pointed to the CDC's recently declaring racism as a public health threat. Can the panelists speak about that or identify other social ills that threaten the health of our society?
I'll try to wrap up both that question and Kari's closing question about salient lessons. I think I would name ongoing settler colonial violence, as well as the abrogation of treaties with sovereign nations, right? I'd also name mass incarceration, right, as a public health, illness, right, that seeps through in the smallest as well as the larger structural forms. And I'd also name medicine's role in larger processes of ability making, right, as another takeaway and issue that has become more visible. This is not to say that this only emerged during COVID, but became much more apparent and visible.
That's, I think, a wonderful way to wrap up. Thank you. So thank you to my fellow panelists and to everyone who contributed such interesting questions and comments through YouTube. The final day of the conference begins tomorrow at 1 p.m. Eastern Time with a panel on genres of empathy, and I look forward to seeing you all then.